Thank you very much. I am delighted to be here, and I'd like to thank the organising committee for inviting me. What I want to do is to share with you our experiences in BC, just so that people can learn from what's been going on. I'm sure most of you are aware that in North America there is an unprecedented amount of overdose deaths occurring. Most of those are due to opioids. They are preventable, but we're not doing a very good job at preventing them. And I think what we have to look at is if this was occurring in people who were middle-class white folks, or if it was an infectious disease, we would be doing a very different job than we are now. I've got so much I want to share, and I'm going to try and really, I know that you don't take away that many things when you sit. As a family doc, I know that you probably left with 4 key take-home points. And as you get older, like me, you're lucky if you've got 2. So what I want to do is really just to give you some information about what's been happening and what we're trying to do, and what we found from that. So first, what I'd like to do is to give you some context. Whoops, that went very quickly. Canada. It's this wonderful country that sits above the US, and don't tell Donald Trump, but we're bigger than the US is as well. And you can see from this that our population and our size isn't that different from Australia. British Columbia is a province on the west coast, so on the Pacific Ocean. And we have provinces and territories. We don't have states. Our drug laws are enforced and legalization. Any sort of drug laws come from the federal government. The provinces oversee the health. They also oversee the coroners and the medical examiners. So we've got these 2 different ways of doing things. British Columbia is absolutely beautiful. And I just want to show you this. I mean, I'm in New Zealand. I'm not going to do a travel log for you guys because I know how beautiful it is here. But, you know, we do have skiing. We do have surfing on the west coast of the island. We do have hiking, kayaking. So it's a really nice place to live. This is just, I thought it would be interesting to compare British Columbia and New Zealand. You can see the size-wise, but the population is extremely similar. So when I'm talking to you about numbers, it'll give you some insights there as to what it would mean if it was in New Zealand. We do have a smaller Indigenous population, but we try and engage Indigenous populations as much as we possibly can. It is so important. So what's actually going on in North America? Last year, 2017, the US had 77,000 overdose deaths. That's 200 a day. It was the leading cause of death in adults under the age of 50. In Canada, there were 4,000 deaths. And for the first time since the AIDS crisis in the 1980s, we saw a reduction in life expectancy, which is huge. I mean, just the effect that it's having. It's very rare that I can actually go and talk to people and not find that an individual has some connection either themselves or knows somebody who has had a connection with and has been affected by people who use substances who have overdosed. So we're obviously in a different situation, but it's something that we really need to be working. We need to be sharing what we're finding. The other thing, when I give talks, usually I have somebody with me who has lived experience, and they tell it like it is. Their voices are much more impactful than mine, and they keep me grounded as well. So in place of that, I'm just going to read a little bit of a paragraph from a story that was written by an Indigenous woman from Vancouver. When I hear the sad song of sirens that ring out in my neighbourhood every day, all day long, I'm dreading the story I will hear, whether this person made it or not. This emergency crisis of overdoses and deaths has taken its toll here, in this city that I love so much. It's inconceivable. It's so hard to understand why this problem can't be helped or solved. Why isn't what we are doing working? And that was written by Tracy Morrison, who was an Indigenous woman who could be found frequently pushing her cart around the downtown east side selling bannock, which is a flatbread. And you could buy that for $1 and a little pot of jam for 25 cents. And sadly, a couple of months after Tracy had written this, she died. And that was in 2017. But it gives you a flavour for what has been going on. A picture is worth 1,000 words, so I'm going to give you 8,000 words and go through what overdoses have looked like in BC, in the province where I live, over time. And I'm just going to flick through these. The darker the colour, the higher the rate. So this is 2010, 11, 12, 13, 14, 15, 16, 2017, we had to introduce a new colour to our maps because we hadn't realised that it was going to get so high. 2018, and these are rates, so this is what we've been seeing to date. So you can see how much darker it's got. So how is BC doing compared to the other provinces in Canada? Badly, in a word. We have to remember, though, that when you look at a map like this, because the provinces collect data differently, we're actually looking at slightly different things. And that's one thing I would say, that if you're collecting data, make sure you can compare over years, but also between jurisdictions. BC collects unintentional illicit overdose deaths, and it includes overdoses that are provisional, that have not been concluded, cases not concluded by the coroners. If we look in Alberta, they collect overdoses due to opioids, both illicit but also prescribed. And then as we move further east, we are seeing only those cases that have been closed. So we're looking at apples and oranges to some degree, but it does give us an idea that you can see there that BC is the worst. And what does this look like over time? You've seen the maps, you've seen how the intensity's increased, but these are the numbers. And I've just indicated on this graph some of the public health initiatives that we've introduced. So Insight opened in 2003, so at that point we had 2 supervised consumption sites. Due to a slight increase in 2011, you can see that little blip above the red line, we started with the Drug Overdose and Alert Partnership. That's DOPE, which David mentioned. That's an intersectoral group of enforcement, ambulance, coroners, health, and people with lived experience who actually look at the numbers. We have regular meetings, and we make sure that we're using the same numbers when we're doing presentations or when we're talking to the press. Take-home naloxone we introduced in 2012, and I am forever grateful that those 2 initiatives were started before the crisis happened. And you can see there how the numbers have just increased astronomically. In 2016, we introduced a public health emergency. It was declared by our provincial health officer, and I'm not sure how it works here, but what that meant was that in public health you can divert resources. But most emergencies come and they go. You have a SARS outbreak or potential Ebola, and you redistribute resources for a short time. That's not happened. This is carrying on, and you can see there that in 2017 it was even worse. The only slight light that you can see there is that it seems to have levelled off for 2018. But with that increase in overdoses with the emergency, it also has helped us to collect data. We can collect data, nominal data with names, we can link it, we can identify who is at risk, where do we need to make interventions, and can we assess those interventions. And also it's helped us introduce supervised, observed prevention sites. So just to put it in context, we now in BC are seeing more illicit overdose deaths than we are suicide, motor vehicle incidents, and homicides put together. So why? What is the reason? And in one word, we could say fentanyl. Fentanyl is a very potent drug. It works very quickly. It's much faster in its action than other opioids, which means if somebody takes it, they can overdose very quickly. That's why it's such a good painkiller for people, analgesic for people who are either post-operatively or for cancer treatment. And these are the numbers that we see in people who have died. We were about 4% in 2012. And you can see just bit by bit, we've increased. We are now in over 80% of people who die from an illicit overdose have fentanyl detected. Now, that doesn't mean that was all that was on board, and we know many times that other opioids, cocaine, alcohol, and benzodiazepines are also identified. But that in itself doesn't mean that the drugs are contaminated. But you can see there the fentanyl has gone up incredibly and is responsible, obviously, for those additional deaths. When we first really, our wake-up call was back in 2014, when we heard there were 31 overdoses that occurred in a weekend at Insight. Usually they just see a handful. But in 2 days, there were 31 overdoses. And because of our collaboration with the police went in, they picked up a cooker, they picked up some of the samples that had been used. People thought they were using heroin. And when they got it tested, it was pure fentanyl and caffeine. There was no heroin in it at all. So that was kind of a game changer to realize that there was so much fentanyl. It wasn't just fentanyl contaminating or being adulterated into the heroin. It was there in its own right. So we thought we'd better do a quick study, find out, is this happening all over the province? We were seeing increase in deaths. It takes a while for cases to be closed and to get the coroner's reports back. So we did a quick study which was asking people at harm reduction sites around the province, can you tell us what you've used in the last 3 days and can you pee in this pot? And what we found was about 13% thought they were using fentanyl. When we tested their urine, it was closer to 30%. And of those where their urine was positive, 3/4 didn't know they'd taken fentanyl. So the press are always telling us people are unsuspectingly being poisoned, and that's a word that's been coming out, by fentanyl. We did a similar study that we've just done earlier this year, and it's 46% of people know that they're using fentanyl. They report that that's what they're buying. And then when we looked at the tests, because we've been examining them, it's about 50%. So people know what they're getting. They know they're getting fentanyl. So why fentanyl? I think it was alluded to earlier. When we look at prohibition, if we look at alcohol prohibition in the US in the 20s, what happened? It's very similar to what we're seeing with fentanyl. Fentanyl's really easy to produce. It's coming in, we're told, from China. It's much easier than cultivating poppies and then having to convert it into heroin. It's small packages can come in. It can be mailed around the province. People can get it mail order, even though that it's being clamped down on. It's cheap. It's readily available, and it's overseen by organised crime. And of course, with organised crime, they're in it for the profit, and the violence that comes along with that as well. So very similar to what we were seeing with the prohibition. Another factor is prescribing. And I'm not sure if you guys have heard the story of Purdue Pharma, who is an American company who developed this wonderful thing called OxyContin, which, surprise, surprise, it wasn't addictive. And that's what they told physicians. They told physicians, you're not treating people's pain. You need to be treating them more. They also put on some symposium and whisked off the pharmacists, the physicians and nurses to nice places when it was warm, when it was probably wet and cold somewhere else. They even gave vouchers for free 30-day amounts of OxyContin, so they could give it to the patients. We're not surprised to see that both Canada and the US had a much higher prescribing rate of opioids, and especially of OxyContin, than Australia or New Zealand or the UK. And would you believe, just before the patent was running out, they withdrew it from the market and introduced Oxy Neo. And this was a new preparation where you couldn't crush it, which meant it was hard to snort, and it was hard to dissolve. But we know people are creative, and if you go on the internet, you can find ways of adding Coca-Cola, microwaving, and doing various things. But that meant a lot of people were sitting up and thinking, okay, we better not be prescribing anymore. So OxyContin disappeared from the market. It wasn't around. So we started getting these fake oxys, and these little green things called green meanies or green jellies are made to look exactly like OxyContin. They have 80 on one side and CDN on the other side. And these were going out and being sold as OxyContin. But they contain fentanyl. And we always give the chocolate chip cookie analogy, that if you're baking, and if you're like me, you throw it all together, stir it up, and then put your cookies out, you can have very different amounts in each of your cookies. So you can have the small amount, or you can have a much higher amount. And if you think of this as fentanyl, you can also think of taking a bite out of that cookie, and you may get no fentanyl, or you may get enough to kill you. And of course, organised crime, there's no quality assurance, it's badly mixed, and this is what's being sold. So then we started getting stories, and this we had a number of incidents and this was August 2015, as you can see the time is going on, when young people were dying. They were getting the OxyContin, which in the past had a set amount, it was standardised, it was a prescription drug, and now they were getting OxyContin that contained very little or a lot. And this was one of, there were two young gentlemen who used it on a park bench. They both overdosed. One came round to find his friend was unconscious, called 911. I think it's 000. I don't know what it is in New Zealand. 000, same as Australia. Anyway, called for help, but unfortunately his friend died. So our Ministry of Health said, right, we've got to do something. Let's get some posters out. Let's send these out and make sure that people know what's going on. And these were ones that came out that were targeted at the youth. I was asked to share it with people with lived experience to get their feedback. So I did that. I got a group together of my colleagues who I frequently work with, and they took one look at them and said, yuck. And what they said was, well, they're dark, they're grungy, they're scaremongering. That doesn't work. The message, it could be in cocaine, crack, ecstasy, meth, that wasn't really true. We were seeing it in heroin and we were seeing it in the fake oxys. The yellow underneath they thought looked like police tape. So I collected all this information, I gave it back to the folks that were developing it, and they said, thanks, we're just about ready to release it, so we're not going to do anything here. And that led to an interesting conversation about respectful engagement of people with lived experience, consultation not just to tick the box, but you should engage people right from an early. And I think we're learning. I mean, and that was only one thing. You can imagine how livid people with lived experience were when they found that they were ignored. Interestingly, I've just got a couple of these. The public developed their own, which were, because these were targeted at youth, and you can see this one which says, drugs are not a game, don't become a ghost, and the eyes on the ghosts are the OxyContin. And then this one, Pac-Man has multiple lives, but in real life you only get one, game over. So I think, that was probably far more appealing to the youth rather than what the ministry and the message the ministry thought they should hand out, which was, there's dangerous things out there, don't use them. And I just want to reflect on something that was said in by Chloe when she was giving us the talk. Although we're saying that yes, it's fentanyl, yes, it's an issue, overprescribing is an issue, but we really have to look at what's causing, why are people using, and go back to the social determinants of health and health inequity, and the effect that adverse childhood events, lack of education, lack of schooling, lack of jobs, unemployment, and lack of housing have in that whole situation. In BC, we've been very focused on responding to the crisis and preventing people from dying. But I think we really have to look upstream and think about what we can do to change this, to think about how we can improve housing. We all know the evidence around housing first, even if it's expensive, even if it's hard to do, but we have to really think upstream. The other issue to bring, and the Indigenous welcome this morning was wonderful, and we certainly have, at most of our meetings, we have an Indigenous welcome or an Indigenous prayer, because again, in Canada, we are visitors on Indigenous lands. Colonisation, and I think it may be different in Australia and New Zealand, but we've got three things that we have to really bear in mind. One is the residential schools, where children were taken away from their families. They were, unfortunately, physically, sexually abused. Because they were taken away from their families, they did not know how to parent when the next generation comes. We had the 60s scoop. That's not talked about much, but that's when children were actually removed from their families. And it was thought that they would be better in foster care than they would learning about their culture, living with their families. And then the land theft, which obviously that's something that's been referred to here. So it's not surprising with the trauma and grief and loss that addiction occurs. But the Indigenous perspective in Canada on wellness is amazing. It's much more holistic. We often talk about addiction. We have to talk about substance use as being, it's a health issue, it's a medical issue, it's not a criminal issue. But if we do that, sometimes we're negating our social responsibility. It's not just a health issue, therefore you can treat it. We have to think about the social implications, the economic, the environmental implications that have caused where we are now, and think of as the Indigenous, and this is from the BC, the human being in the centre. And focus on cultural safety and cultural humility. There is no way I know how somebody feels, what experiences they've had. I have to be humble and say, tell me, how can I help, what can we do? And of course, trauma-informed practice. We don't want to re-traumatise. I just put this up when I talked about social determinants. I realised that in Canada, we don't do very well with child poverty. And I was surprised to see that, okay, we rank 13th, and Australia ranks 11th on this. In BC, it's an embarrassing 1 in 5 children live in poverty. It's disgusting. So, how are we responding? So, one of the things we can do is to track and reduce prescription opioids. Great. Opioids are a cause. Prescribing is a cause. Let's reduce the prescribing. We can track with prescription drug monitoring programs. There was a recent article where somebody did a review. It was published, I think, in the Annals of Internal Medicine and showed they don't have any effect. Reducing prescribing, that's fabulous if it's when somebody is being first given painkillers. So there's a recent study by I can't remember, in JAMA, where they actually looked and found that opioids were no better than using other analgesics for arthritic pain, for back, for knee, for hip. And another study which it was presented, I think, just a couple of weeks ago and will be published soon, which showed that by educating physicians and also the patients, you can actually reduce the prescribing and the number of prescriptions that people will fill by that education piece, and that was for gallbladder and for hernia surgery. So we can do a lot. We can improve what we're doing and making sure that we're giving appropriate treatment. But unfortunately, what we're finding is that there's regulations coming out of colleges. Physicians are getting scared. They're concerned that they're going to be held accountable, maybe lose their license because they're prescribing. And this is just a quote from one of the studies that we did recently. I don't know why, but everybody's been getting cut down or cut off opioids. Like, I got a broken neck and I've got chronic pain. It's just chronic, always in pain. Now, for a doctor to say, people are selling them on the street, therefore I'm cutting you down to half a dose, and then we're going to wean you off within a 2-week period. Well, does that give me a new neck? And of course, if people are cut off prescription opioids, and we're not dealing with their pain, whether it's emotional, whether it's physical, and they're going into withdrawal because they're not getting it, what are they going to do? They're going to go to the illicit market, and surprise, surprise, people are using the illegal drugs which contain fentanyl and dying. So we have to really be aware of unintended consequences when we're actually putting interventions in place. Another point I'd like to make is this treatment versus harm reduction. I've been doing harm reduction probably about 15 years now. And throughout that time I've heard, well, you know, I'm believe in abstinence and recovery, and somebody else believes in harm reduction. But what we have to do is to make sure that people have what they need at that point in time. Substance use is a journey. It's not either or. One of the phrases that I hear frequently said is that you cannot treat somebody when they've died from an overdose. We need to meet people where they're at. We don't say you must give up using smoking cigarettes before I'll treat your chest infection, or go on a diet and lose weight before I'll treat your diabetes. We have to meet people where they are and find out what it is that they need at that time in their journey. We also are aware, because of this crisis, that we have seen people who have come out of, especially residential treatment, who have then been unfortunately using, and because they've lost tolerance, have died. So we need to talk to people about how they can be, if they do use, try and support them through their abstinence, if that's recovery, if that's what they're wanting, but make sure that they know that there are things that can help them be safe. Opioid agonist treatment is another thing that we've really ramped up. We used to just have methadone as the main treatment. Now Suboxone is allowable through as a first-line treatment, not just for those that have failed methadone. We've increased it dramatically. It's easier for physicians to prescribe. We've made sure that people can actually get reimbursed for opioid agonist therapy. But we're still not doing very good at having people retained on it. People will go in and have an overdose, be seen in the emergency department, have an acute care team around them, get started on treatment, but we have to make sure that they have the supports to continue. We've introduced quite a bit of injectable opioid agonist. We, in Vancouver, you're probably aware, we had the Naomi trial, the North American trial, and then we had Salome, so that was diacetylmorphine. So we started off with the heroin trial, and yes, this was people that did not survive, did not really find that methadone was helpful, and it radically changed these folks' lives, because they weren't spending their time looking for illegal drugs, trying to get money to buy them. They were stabilized. But of course, our government at the time, which was not supportive, said, okay, you've done the study, no, we're not going to let you carry on with this, even though you've shown that it works. And then we had Salome, which was hydromorphone, again, injectable. And we've got people who are being physicians that are being very creative. We have one who will prescribe, and then it's observed injection at the local pharmacy. So we've been trying to do things so that people can use safe drugs, because we know that in the illicit market, they're very unsafe. Drug testing and checking, that's something that's is really taken off. Although you will find some people are a bit skeptical. If you've got fentanyl in 80% of your down, in 80% of what people think may be heroin or down, is it really worth testing? The chances are that you do have fentanyl. But I think in regions where there's less fentanyl, as you saw across the country, or even if somebody is wanting to check their cocaine or other drugs, then it's very worthwhile. Naloxone programs, and I've noticed in the program there's lots about naloxone, and I'm delighted to see that because that's my passion. We started with our program back in 2012, as I showed on that graph. We use injectable. When we started, we really targeted where people were at highest risk and made sure that the program was available to them. Since then, it's become unscheduled, so anybody who uses drugs or anybody who thinks they may witness an overdose can go and get a free kit and get training. We have about 1,500 places that you can go to get it. All our correctional facilities offer training before release. All emergency departments offer take-home naloxone. We're also in 600 community pharmacies, so people who don't necessarily want to go to a site which is known to serve people with who use drugs, that they can go to the local pharmacy and just get trained and pick up a kit there. And you can see that you can put your postal code and see where the nearest place is. This is really showing that we have handed out 120,000 kits since we started. Over half of those were in 2017. It's huge, and a quarter of them have been used. And if you can imagine, with those kits, people lose them, they get out of date after a couple of years. So for a quarter to have been used, that's huge. We've done a number of evaluations. We've evaluated it in the correctional facility and how we can improve that. We've evaluated it generally, and we evaluated it with the kids. With young people, they were so engaged with the program, and they're not always engaged with programs, as I'm sure some of you would agree. But there was something about the take-home naloxone, so we did some qualitative work and found that they felt people genuinely cared about them. They trusted them. So we had some quotes, and the youth actually illustrated, and we made some postcards. The other thing youth said was that your training videos suck. So we had to, we redid it with their input and using some of their graphics. This is interesting. One of them said, well, it should be in all the single room occupancy hotels so people can just access it. And this is illustrated here, and this is what we've done. So in single room occupancy hotels, there are these boxes. You don't have to have a key or anything, you just open it. When it opens, the alarm goes off, or there's a connection to the staff member. You can see there on the one on the right, it's actually you can speak to the staff. It gets checked 3 times a day, so it's there, ready, available if somebody overdoses in their room or anywhere else. And, we need all the help we can get. This is the facility overdose response box is for organisations that have overdoses, but they, instead of having kits that they have to replace and replenish, they have boxes with 20 naloxone in, and we keep an eye on what's going on. So supervise and observe consumption sites. We had 2 supervised consumption sites. We had this crisis going on. We were submitting applications for other supervised consumption sites. It had to go to we get what's called an exemption 56, which is under the drug laws, the Drug Act, and it has to be approved by Health Canada. And we were waiting, and we were having to jump through hurdles. Meanwhile, people were dying. So, people in positions with the province and others weren't doing anything apart from trying to get it moving. And it took a couple of real advocates to say, okay, enough already, we're going to set these sites up. And so they set up these tents in the alleyways, and people came and they injected the drugs. This was in Vancouver, and the police said, yeah, that's fine. People are dying, people are overdosing. You could walk down the street and you could hear people shouting Narcan, but by the time you got there, there was already somebody who was actually reversing the overdose. So the kits were out, but it was happening in the back alleys, and it could happen where somebody wasn't going to be found. So in December, the minister said, okay, we need to do these overdose prevention sites, and we'll do these under the Act. And these are supposedly temporary. They're often run by people with lived experience who are the first who are actually manning them and responding. New sites, but also mobile sites as well. This is an example of one in one of the hotels. There are sites there, very basic, and then there's some that are a little bit more friendly. So what are these sites? What's happened? We have had hundreds of thousands of overdoses. We've had hundreds and thousands of injections that have been supervised. We've had thousands of overdoses reversed. And we haven't seen any deaths in any of the sites. We've had 31, now have 31 observed sites, of which 8 are supervised consumption, so are legally sanctioned. The rest are ones that are set up in different places. This is one of my colleagues at the BC Centre for Disease Control has calculated how many deaths averted there have been. And you can see here that it really is the take-home naloxone has given us quite a number of overdose deaths that have been averted. It doesn't mean these are life saves. These are sometimes people who have repeated overdoses that we can see there. This is what's happened. You can see that real shoot up in November, December of 2016. We thought we were doing well. It seemed to be levelling out. We had an awful month in March. So it's still high, but not as high as it has been. One of the things that we have to work on is our language. We put this together with people with lived experience about using the right words, making sure we talked about people first language, and also to get away from the clean and dirty to say whether it was a positive or a negative test. So I took this to the media and said, hey, this is what we'd like people to say. And then this is one of the articles that they wrote about it. Don't use disrespectful terms such as junkies to describe addicts. Lost in translation there. And the other thing we found is that people with lived experience are really finding meaning in employment, whether it's being the peer-to-peer training for the take-home naloxone or whether it's working in these overdose prevention sites, even though they're earning far less money than those that are employed as a nurse who probably are sitting observing, making sure that things are okay. Many folks are reporting that they've reduced their substance use. As I said, lack of recognition and compensation. And I just love some of the things that people with lived experience will say. I used to be a criminal, now I'm a lifesaver. And I'm doing exactly the same thing, which is seeing people use drugs and being there to help save their lives. And from a dealer to a healer. So my take-home messages are really, the overdose crisis can happen anywhere, anytime. Fentanyl just flooded into Canada. We weren't prepared. We didn't know it was going to happen. So make sure you've got good data that you know when it is going to, if it does happen. Always consider unintended consequences. We have to think about having the right solution for the right person at that time. So treatment and abstinence, yes, but we also need to make sure we've got harm reduction and we've got all the different parts of harm reduction in there. And we always have to include the experts, people with lived experience. Let's think about our language as professionals. People look up to us, and let's see if we can try and use that person-first language. And let's reclaim compassion. If I want to get depressed, I look at the comments under an article about people who have died or whatever in the news. If I want to get my belief back, I talk to people with lived experience. I see folks, their resiliency, how they're supporting others, how they're really committed to their community for very little compensation. And what next? Decriminalisation is the first step, and then regulation is the next step. So we need to think outside the box. We need to do something. We've done a lot, but it's not made a huge difference. Although without it, it's really unimaginable to know how many deaths may have occurred if we hadn't done all the things. Thank you.